And just to let everybody know, we will be recording today's session for educational purposes to share afterwards. So welcome everyone. I see people continuing to join. My name is Camelia Rodriguez-Sackburn, and I'm with the Global Brain Health Institute. And I should say good morning, afternoon, or evening, depending on where you're calling in from. Today's program focuses on track 2 of this Global Neurology Forum series, Exploring Core Challenges. We have participants from around the globe, including guests from outside the Global Brain Health Institute, outside of the UCSF MAC, and the Global Teleneurology Service community. You are all welcome, no matter where you are calling in from. A special welcome to our Atlantic Fellows and Senior Fellows joining from GBHI. Just a few housekeeping items. We encourage you to share your questions and thoughts in the chat box, and a special thanks to my colleague Kira, who's going to be monitoring that chat box for us. Please mute yourselves to avoid any background noise. The program is 90 minutes. It will be recorded, as mentioned, and posted online. One sec here. Okay. These presentations are provided for educational purposes only. The program is not designed to provide advice on care of patients, which remains solely the responsibility of the physicians in country. Our topic today is the contributions of HIV to brain health internationally, and I would like to invite my colleague, John Van Leeuwen from the Global Teleneurology Service at UCSF and GBHI to introduce our speaker. Thanks, John.
Thanks, Camelia, and thank you all for joining today. It's really a pleasure to introduce Dr. Victor Valcour as our presenter today, and we're delighted to have him, not just because he's joining us while on vacation and still willing to do this presentation and fighting some interesting elements in order to make it happen, but really it's been great to work with Victor. Many of you already know Victor. He's Executive Director of GBHI and Professor of Geriatric Medicine and Neurology here at UCSF, and Victor's really been at this, the origins of this series, and something we've conceptualized this series together, and it's been fantastic working with him and seeing this grow. And one of the things I appreciate about Victor is that he consistently challenges people to view issues from different perspectives. And I think that's something that he's even challenged of himself, and we see perhaps reflected in his training, received training in both geriatric medicine and neurobehavior. And today will be fantastic to hear more about his research and things he's been working on and other issues. So his international research addresses the prevalence and characteristics of HIV-associated neurocognitive disorders among patients aged 60 and older. And this work spans several continents, including North America, Asia, and Africa. So I'm excited for his talk on the contributions of HIV to brain health internationally and the discussion that will follow. So with that, I'll hand it over to you, Victor.
Thank you, John. Thanks for that kind of introduction. Can you all hear me well enough?
Yes, we can hear you.
Yeah, good. Camelia is going to advance the slides for me. I agreed to do this many months ago, and then I chose to take some time away, and I didn't want to cancel this. So I'm delighted to share some of this work. It really is a lot of the work that I do internationally with the grants that I'm currently running and some of the work that we have done in the past. And I hope it's helpful to many of you who are caring for people with cognitive disorders around the world. It's storming here where I am. I just opened the door, so maybe you can see me a little bit more. I let a little light in, the rain has stopped. If it gets too noisy, I'll close it, but I expect the sun will come out and you'll be able to see me better. It's unusual that there's such a storm going over. I'm in Minnesota, and hopefully it'll get lighter as talk goes on. So if you can go to the first slide, I'll share with you that the next slide, Camelia. In 2016, these are numbers from the UNAIDS that indicating how big a challenge HIV is around the world. An estimated 36.7 million adults and children living with HIV. We really don't even know how to fathom that size. If you think about even with the COVID epidemic, the number of people infected compared to this 36.7 million. Unfortunately, about 17,000 of them aren't on sustained treatment around the world. This greatly increases the risk for brain injury by not being on treatment. And we're still seeing many, many new infections as well as deaths due to HIV. So if you can go to the next slide. In terms of the burden, there is really a concentrated burden in sub-Saharan Africa. 1 in 25 adults in sub-Saharan Africa is living with HIV. You can see from these numbers in 2017, UNAIDS, some of the regions that have the highest percentage, including Swaziland at 27.2. We had Primrose on the call, and Zimbabwe, 13.5% of population, at least in 2017 by UNAIDS, was estimated to be living with HIV. And as a consequence, because HIV can cause cognitive inefficiency and challenges, probably in a third to half of people living with HIV, even on sustained treatment, you can easily determine that the leading cause of cognitive impairment worldwide is HIV for people under the age of 60. I'll talk a bit about the reason why I use cognitive impairment and not dementia in a bit. This is really not a disease that with treatment frequently moves on to dementia, but it is a persistent, and I'll say fluctuating, cognitive impairment that may have implications for susceptibility to neurodegenerative disorders as people age. Going to the next slide, I really like to share this slide. Sorry, a little bit of noise. This slide, because it really pulls home the challenge of this problem. It's easy to say sub-Saharan Africa has large numbers of individuals, but if you look in the United States, among a population of Black men who have sex with men, the rate of infection is higher than it is in many of those countries in sub-Saharan Africa. So we have populations within the US, particularly stigmatized populations, that have very high frequency of HIV, and as a consequence, higher risk for HIV cognitive impairment, related cognitive impairment. If you go to the next slide, I pulled together a number of international studies trying to estimate what the frequency of cognitive impairment is for people who are on therapy. So one clear message from this talk is that the leading treatment for cognitive impairment in HIV is suppression of plasma viral load, getting people on therapies to suppress their plasma viral load. So I tried to find studies where we have looked at people who have suppressed plasma viral load to get an estimate of the frequency of impairment. And you can see from these numbers that they really are quite broad, from a study in Switzerland where it's almost 70%, really almost unbelievable level of impairment, yet also a study in Malawi that's 14%, which seems to be a little low, particularly since only 75% are on CART. When I really started looking at this, the number that really resonates with me as most likely is the one from Botswana and Thailand, around 38. I think that's about right. About a third of people living with HIV on therapy have suppressed viral load. I hadn't remembered, but I'm actually the author on the Thailand paper. When I pulled the paper to look at it more carefully, this is a cohort of people that were started on NNRTI treatments many, many years ago, and we did cognitive testing on them after they'd been on therapy for almost a decade with suppressed plasma viral load, and we still found about a third met criteria for cognitive impairment. If you go to the next slide, you've heard me talk a little bit about the word cognitive impairment rather than dementia, and the challenge that relays is, well, if it's not dementia, do we really need to worry about it? I like this picture on the bottom. I've been here, maybe some of you have as well. This is in Zambia. I think there's now a bridge that goes across the Zambezi River into South Africa. At the time, there wasn't, so people would line up to get on a barge to go across the Zambezi River. This is a major trucking route down Africa, and through virologic analyses in South Africa, we know that this is one of the main routes by which HIV entered South Africa, through the trucking routes. So people would sit here and wait maybe days to get on a barge to go across into South Africa. And that idle nature, that waiting, opened up a lot of opportunities to do things that maybe could put you at risk for HIV, and there's a lot of prostitution around that area of the country. And so we know from other studies that have been done in South Africa that a lot of these truckers are living with HIV. So what does it mean to be cognitively inefficient and be, driving a big rig across, Africa? There have been studies, in fact, that this inattentiveness increases risk for accidents. So even in the degree of mild impairment that we see, there's quite a substantial risk in places like this. So I think it is a very important risk factor. Go to the next slide. I direct the cognitive and mental health aspects of a large study in Africa that includes Tanzania, Uganda, Kenya, and Nigeria. We've enrolled almost 4,000 individuals at this point. About 1,000 of them are HIV uninfected. And so this pie chart gives you a little bit of a sense of our test and how people perform on that test. We defined impairment based on how people perform on this battery of 6 tests. And what we can find is that 26% of our non-infected individuals test in an impaired range and 38% of our HIV positives. So for those of you who are not very comfortable with neuropsychological data, I might share with you, first of all, that if you gave a battery of tests, and it depends on how many tests you give to an individual, if you give a battery of tests to a population of very, very healthy people, some will meet impairment criteria if you define it as -1 standard deviation on 2 tests or -2 standard deviations on 1 test. And depending on the number of tests you give, that number moves around a little bit, but it's probably around 15 to 20% of people will test in an impaired range. So our HIV negative individuals probably exceed that population. The important thing here is that our HIV negative group is more demographically matched to the HIV positive group. So they may be using substances, they may have had head injuries, they may have low education. What we can tell from this graph is that there's an incremental addition due to HIV in the rate of impairment, but there is also a background rate of cognitive challenges. This becomes a very interesting question for us when we started to look at it in terms of inflammatory markers. A pilot study that we did looking at inflammatory markers found that in both HIV positive and HIV negative individuals, the amount of inflammation you measure in blood correlates to performance on cognitive tests. This shouldn't be surprising. There have been 2 or 3 big papers showing that the IQ of a region is inversely proportionate to the number of parasites that exist in that population. So there's probably a risk to the brain that's happening around the world related to the burden of parasites. And the mechanisms are not perfectly clear. You could imagine some of these parasites are enteric, many of them are. So maybe this is a nutrition issue that's affecting IQ. But we were able to show in a study out of Kenya and Uganda that there's an inflammatory moderator or mediator in some way that also correlates to the performance in both HIV positives and negatives. This is a pilot study done by an Atlantic fellow that published by Arnold Muñoz, who's a fellow from Mexico who used this data set to publish the paper. And it led us to now measure inflammatory markers in the whole cohort. So we're now examining in 3,000 Africans, both HIV positive and negative, the contributions of inflammation to cognitive performance. And I think that may be a major paper that will come out from the work that we're doing. But the key thing here is that there is an incremental addition from HIV. So in the next slide, we also look quite a bit at depression, anxiety. We look at gender-based violence. We've looked at PTSD. And these are some of the early data out of the AFRICOS population. Again, high rates of depression, seemingly a little higher in Tanzania compared to Kenya and Uganda. We didn't include the Nigeria data here. And what's interesting here is that depression and anxiety not only seem to correlate to whether you have an undetectable viral load or not, but it also seems to correlate to whether you will have a poor outcome down the road. These are data we're working on now. So if you enter our study with a high burden of depression and anxiety, it appears in our early analysis that you're more likely to fail antiretroviral therapy in the future or to have a detectable viral load. These are probably behavioral factors that are influencing people taking their medications. Some people think that it may even have an influence on the inflammation that people are having, depression, increased inflammation, and so forth. These are some of the questions that we're going to try to answer in the cohort. But this is a critical policy issue because our goals, as many of you may have heard, are the 90-90-90 goals that are mentioned over and over and over again. If we can identify 90% of people with infection so that they know their status, and if we get 90% of them on antiretrovirals, and if we get 90% of those on antiretrovirals to be undetectable, we can have a public health approach to curing HIV. If we can't reach those 90-90-90 goals, why is it? Well, it appears that treating behavioral issues is an important aspect of reaching those goals. If this can be demonstrated in this cohort, you can imagine the policy implications that could have. The next slide. So just to collect, with proper treatment, HIV tends to cause an impairment without typically progressing to dementia for most patients. I tend to call it a fluctuating chronic encephalopathy, meaning that that people can do better one day, worse another day. They can have good days and bad days, and these are very commonly heard. And inefficiency is what I tend to see. So what does that mean for individuals? They can't do things as rapidly as they used to. Where they feel this the most is in conversation, at parties, the banter that is helpful to be able to pick up on what people are saying and respond quickly. Is an area that they tend to find really exacerbating. And if they have to multitask doing complex things, that's difficult as well. Although it's a cognitive impairment, it does speak to brain reserve in a manner that would make me think people will be more vulnerable to age-related dementia such as Alzheimer's disease. I'll have just one more slide on what this looks like. The next slide. Unlike some neurodegenerative disorders where we know there's selective vulnerability to the brain, for example, frontal temporal dementia is a classic example of selective vulnerability in the early stages, it appears more that HIV has a more ubiquitous impact on the brain with some challenges in cognition, behavior, as well as motor. In treated individuals, among people who are on treatment, we don't see as much of the motor problems, although I have published several papers showing some increase in the United Parkinson's Disease Rating Scale, but it's minor. We see a lot of apathy and depression. And at least several papers have correlated that to the amount of inflammation that people have. So this is not just a reactive depression, I would say. And then the cognitive piece I've talked about. Really some mental slowing, concentration problems, often presenting as what appears to be memory problems. I want to switch now and share with you some of the research that we've done that's working on HIV. Some of this is international, some of this is work that we're doing in the US. So I'll start by telling you a story of PSOC. PSOC is a participant in one of our research studies in Bangkok, Thailand. So if you go to the next slide, PSOC, P is PI in Thailand is used for kind of colloquially for someone you like, a friend, you know. So a good friend would be like you would say P Victor, or if it's more respected, I guess Kun Victor. But PSOC is just kind of a colloquial, nice friend. So this is not his name. Sock is not his name. But PSOC is a 27-year-old Thai man who worries that he may have been exposed to HIV last weekend. So 7 days ago, he thinks he might have had an exposure. So he goes to the anonymous clinic in Bangkok, which was in the picture before, and he's told he does not have antibodies to HIV. He's told he's HIV negative. This is what most people around the world would be told. You get an antibody test, you haven't developed antibodies. So then you're told this story that you need to come back if you really think you were exposed because you could be in that window period before you seroconvert and develop antibodies. But instead, he enrolled in our study where, if you go to the next slide, we measure using PCR technology whether somebody has the virus. And we do this in a pooled fashion so that we don't have to measure PCR on every individual, which is just too costly. Every day we batch all of the serum that comes in that day, and we test for PCR. If the PCR is negative, then we are done for the day. But if it's positive, then we have to break it down into groups of 100 and then groups of 10 and then individuals to identify the person who's PCR positive but antibody negative. By the next morning, we call that individual and have them come back in for confirmation. And so PSAC went through this. And if you go to the next slide, you can see that by 8 days after he was exposed, he was diagnosed PCR positive for HIV, antibody negative. So he's a seronegative HIV positive individual. He underwent a intensive clinical evaluation that includes lumbar puncture, cognitive testing, MR, a 1-hour MR protocol that includes spectroscopy to look for inflammation, and then he starts antiretroviral therapy, the next day. So this is a highly accelerated diagnostic algorithm with a lot of clinical work. But having done that, and we now have over 700 individuals enrolled in the study, we are beginning to understand when the virus causes challenges for people and whether these individuals will be protected from consequences of HIV because they started therapy so early. This has a lot of implications for cure, and I'll talk about that in a bit. If you go to the next slide, you can see some of the neurologic data that we have been able to accrue from this. If you look at the blue triangles here, you can see that we've identified HIV virus in cerebrospinal fluid as early as 8 days after estimated exposure. So there's really little doubt this virus is in the brain compartment, at least in the CSF. We don't know, in the parenchyma, although I'll show you some data a little later that it probably is. We know that it has entered this central nervous system compartment very, very early. So this is a neurovirulent virus, well known. If you look at the next slide, we also know that quite a few people will present with headache. So in this slide, in our study, we found about 2/3 of the people. Very interesting, you may know that HIV, you would look for lymphadenopathy in that time, but we found very little adenopathy in these individuals at very early stages. So maybe it was before some of that reactive change, but the classic teaching is that you feel lymph nodes in people to see if they're swollen during that time. If you go to the next slide, I apologize, this is probably not the best slide to demonstrate it, but what we found is that 25% were impaired on cognitive testing when we first took a look at them. Now, a lot of factors could be related to that. It wasn't a very high rate, but we saw substantial improvement over the next six weeks on individuals who were testing poorly before. So it probably was not good for them. We found that impairment was associated with higher CSF HIV RNA and also with MR spectroscopy markers of inflammation. So probably there is some kind of inflammation that's occurring. We find elevated choline on MR spectroscopy. I don't know if I think I have a slide coming up later, but choline is, on cell walls. So when you see elevated choline on spectroscopy, you think that there are more cells that are in that area of whatever you're imaging. Well, the way you get more cells in the brain is infiltration of inflammatory cells. And so we infer that increased choline means that there's inflammation going on in the parenchyma of the brain, and we do see that. If you go to the next slide, just quickly, 53% of the people have some kind of neurologic finding in those first 12 weeks. It tends to be quite mild, but we do see it. And if you go to the next slide, you can see that there's quite a bit of psychiatric comorbidity very, very early on. You could surmise that this is all reactive, but interestingly, the level of neopterin we found in the blood kind of predicts worse depression and worse anxiety. So there's an inflammatory component as well as a potential reactive component. If you go to the next slide, we like measuring monocyte-related markers because we think the monocytes are quite involved in what's happening in the brain. So we measure neopterin here, and you can see with the yellow dots that even in the early stages, we see some elevation of neopterin in the CSF. The dotted line represents where what the threshold should be for normal, and you can see quite a few people are above that. And then the next slide is demonstrating, as I've already said, that we can find elevated choline during acute HIV. That's higher than what we see in people living with chronic HIV, and both are higher than what we see in normal controls. So that's essentially telling you that very, very early on, the brain is involved in HIV virus. And we, of course, follow these people on treatment, and most of these findings resolve. Surprising to us a bit, we still see elevated neopterin in plasma, even 2 years later. And this probably will have some implications for individuals, but we haven't really seen frank cognitive problems down the road. We're beginning to model that using machine learning to see if there are predictors of worse neurologic outcomes. You know, some of our participants here have been followed over a decade now, so we have quite a bit of data. Let me go to the next slide and just tell you, why is HIV, acute HIV, important? Well, it's not so important solely for the neurologic part. Really, these studies are based on trying to cure HIV. And we've been able to find out quite a bit about where HIV is in the body through these studies. The one that is really most interesting, I think, is what's happening in the gut. If you read a textbook, you will learn that the CD4 cell count remains high, usually for 5 to 7 years after somebody has HIV infection, and then it begins to drop, and it puts people at risk for opportunistic infections. What we've learned from this study by doing sigmoid biopsies on individuals is that, in fact, you lose the vast majority of your CD4 cell counts within the first week, month of infection. What happens is that your blood CD4 cell counts remain elevated to protect you, but you've lost a tremendous amount of your gut barrier. This puts people at a higher risk for microglial translocation, parasites, anything that can cause inflammation can transmit from the gut to the blood very quickly. And this may be part of the inflammation that we see and may explain some of the fluctuation that we can see. If you go to the next slide, the other really interesting thing about early HIV is the ability to minimize the reservoirs for HIV around the body. So if we can get people on therapy so early, can we limit the amount of HIV that is in reservoirs? And so if we can do that, will these individuals be more likely to be cured of HIV with any cure strategies that we try? Because the cure strategies are really limited by the amount of HIV that's hiding, usually in inflammatory cells, usually in lymph nodes, also in the brain. Every organ, they seem to find some quiescent HIV DNA, so it's somehow in the cells, integrated into the genomic structure of those cells. This is why HIV is so hard to cure. So what we found is, indeed, if you measure HIV DNA, you find that in some people it is extremely low if you get them on therapy very, very early. Some people think, in fact, that you could just treat them for 2 years and take them off therapy and they may be able to do okay. That has not been our experience. Taking about 7 of these individuals off therapy, they all bounce back with virus. We've tried numerous ways of using vaccines, other therapies that would wake up these reservoirs to allow antiretrovirals to work. Unfortunately, in this very, very early cohort, we haven't found any cure strategies that have worked. Can you skip ahead to 2 slides? We'll skip from that slide 24 and go to slide 25. This is an interesting ethical dilemma that we've had to work with. I've been very excited that we have a group out of North Carolina that received NIH funding to just look at the ethics of cure studies within our population. But PSAC, as I told you, he's antibody negative, and we put him on therapy and we dropped his HIV RNA level so that he never had that exposure to an antigen to develop an antibody. So if you measure him for HIV antibodies a year later, he's still antibody negative. This has a tremendous social implication because in some places around the world, including Thailand, they can do random HIV testing. And in many places around the world, if you want to get a passport, they'll ask for an HIV test. So the test that would be done, in effect, PSAC would be thought to be negative because he doesn't have an antibody. If we then take him off therapy, he will become positive. So there's a little bit of an ethical dilemma in how we do our work to make sure that we just shutting the door because it's starting to rain. That we make sure that we informed him of this social risk of being in a study. This is the kind of risk that you don't usually think of a drug causing an adverse event. But in his studies, if we put him into any cure interventions, we would want to take him off therapy to see if it's a cure, and he would then develop antibodies. And in fact, this has happened to a number of people in our studies, and we've handled it, I think, in a very ethical way, thankfully, because we have great partners who are stars in ethics that have worked with us on this. So if you go to the next slide, I'll just close PSAC's story by telling you the starting treatment at such an early stage of infection is thought to have the largest potential impact on cure because of the reservoirs being low. The brain is involved in HIV at the earliest stages of infection, and the symptoms tend to be present, but they also tend to wane. Regardless of suppressing virus with antiretroviral therapy, inflammation continues, and this is the neopterin that we measure in blood that may be worrisome. So that's just one aspect of the research that I'm engaged in Southeast Asia. If you go to the next slide, although the anonymous clinic is here, I'm going to tell you about Martin's story. Martin, again, not his name, is a research participant in my studies in San Francisco. So Martin is not Thai. If you go to the next slide, I'll tell you, Martin is a 72-year-old Caucasian man living in the US and has been living with HIV infection for at least 30 years. He's on treatment with continuous plasma viral load suppression for at least 15 years. Now, he came to see me because his brother died of Alzheimer's disease at age 69. And now he is seeing that he's having the exact same symptoms that his brother had. He wants to know if he has Alzheimer's disease. This is a very common scenario now. People are living into the ages where risk for neurodegenerative disorders becomes a real challenge, and yet a third to maybe half of people will have some kind of a cognitive syndrome due to HIV. How do you differentiate whether this is early Alzheimer's disease or is this just the HIV-related cognitive impairment with fluctuation? If you go to the next slide, just pointing out that the population is aging around the world. These are old data from the US, where we used to say by 2013, 50% of people will be over the age of 50. Now we have far exceeded that, and we're beginning to look at people living with HIV over the age of 60. Next slide, if you would. This is not just a phenomenon in the United States. Aging is happening around the world. I'm sure in Zimbabwe, people are on antiretroviral therapy and they're living with HIV. The last time I looked at our data set out of AFRICOS, we had several 80-year-olds living with HIV in Africa. In fact, there's been one paper showing that if you get on therapy, your life expectancy in Uganda is quite similar with or without HIV if you're on effective therapy. So we're seeing a lot of people living into older age, and this is an increasing phenomenon of do they have a neurodegenerative syndrome in addition to living with HIV. If you go to the next slide, I'll tell you a little bit more about Martin. He was diagnosed with HIV in the mid-1980s, and his lowest CD4 cell count ever was never below 200. He never had an opportunistic infection. So he's had a fairly not extensive damage from HIV. He was diagnosed in the mid-1980s, but we know for certain that the virus was in the US in the 1970s. I remember a story of an individual who had a brain biopsy in the mid-1970s. They never found the pathogen. I suspect that was probably a seroconversion for him, that he had an encephalopathy due to. We have people in San Francisco who were involved in a hepatitis B study. And when the diagnostic test for HIV became available in 1983, they went back and measured to see if they had been infected in the late 1970s and found quite a few people who were. So even though the test wasn't available until the mid-80s, when somebody tells me that they were diagnosed then, I don't really know when they were infected. Could have been, quite a bit of time before that. He's on a very effective therapy with an integrase inhibitor. He's been on antiretrovirals for 15 years and suppressed. His current CD4 cell count is high at 850. He's undetectable. He has a few comorbidities, including cardiac disease with a past myocardial infarction, and he has, you know, a good educational background. Next slide. He tells me that he's had a subtle, insidious decline in his memory and executive functioning that started about 4 years ago. He is functionally independent. He does have some depression, but he's been on therapy and it's stable. And when I do the neurologic exam with him, the only thing I find challenging is that he has a difficulty with sequential hand movements in the Luria sequence and some mild neuropathy. If you go to the next slide, it's a little difficult to see, but we actually did find some visual memory impairment with him, not list learning impairment, but visual memory impairment. Sometimes that can be because of executive functioning, and that might have been the case for him, but at least he did have some memory impairment. He had some language impairment on confrontational naming. He didn't do as well as one would expect. I don't often see that in HIV. You know, HIV would typically be described as more of a subcortical pattern versus cortical, although many people don't like to use that kind of terminology. But you often will see sparing of confrontational naming with the Boston naming test, and often we'll see sparing of animal naming. Sorry.
We can still hear you, Victor. We just don't see you.
You can still hear me. Yeah, no, somebody called me on my phone, so it interrupted and I can't see anything. So let me know if you stop it. Well, I have you can let me know if you stop hearing me.
Okay, we can hear you beautifully.
I'll keep.
Oh, there you are.
Yeah,
We can
okay,
see you now too.
Yeah, hopefully the person will call back. So I was just saying the cortical language, we don't usually see a problem with the Boston naming, and we don't usually see problems with animal naming. We see a lot of problems with D words or phonemic fluency. So those were kind of atypical components, but then also some typical things, a little bit of executive problems, some information processing, and a little bit of motor slowing. So it was really quite difficult to know what was going on. If you look at this next slide, this is his MOCA, and you can begin to see that he probably has some executive challenges that are feeding into the visual impairment. His clock is almost got a bizarre component to it. I was witnessing how he created that, but it was a little bit unusual, making me think it may not be pure memory problem, but maybe more like executive functioning. If you go to the next slide, you can get a couple pictures of what really was read as a normal MRI, which is very common for people with HIV cognitive impairment. Imaging doesn't tend to help. Sometimes I see absolute profound atrophy and somebody tests perfectly fine. They certainly have a lot of reserve I worry about. But often we'll find that rather normal exam and have cognitive impairments. We'll see varying degrees of white matter lesions. Doesn't always correlate perfectly with cognitive impairment, although we see some evidence that it affects executive functioning. So the imaging doesn't tend to be very helpful in terms of confirming, although it does help you to make sure other things aren't going on. If you go to the next slide, you can see where we are in this conundrum. We have somebody living with HIV who could have an HIV-related impairment or a neurodegenerative process. And this is not something we worried about when somebody's 30 years old, because the neurodegenerative processes are very infrequent. But now that we have people in their 70s and 80s, we really have to wonder, will there be an increased risk for having Alzheimer's disease or other neurodegenerative syndromes, altered phenotypes, accelerated course with decreased reserve? If you go to the next slide, a high-profile article where somebody argued that they were the first people to find Alzheimer's disease. This is what came out in the popular press, that it was the first case of Alzheimer's disease diagnosed in HIV. Most of us in the field said, well, we've seen many. This is just the first one that was published and had amyloid PET scanning done. But this is an increasing phenomenon that we're beginning to see. If you go to the next slide, I've talked a lot about reserve, and one thing we know is in Alzheimer's disease, if you also have cerebrovascular disease, you're at higher risk for the clinical manifestations of Alzheimer's disease. And we think that the same is going to be true for HIV because of its impact on brain reserve. There is another call. Let me know what it is. So Hopefully it won't call back. Sorry about that. You still hear me, Camelia? Yeah, okay. So will we have an increased brain reserve challenge, in people living with HIV, and will they be at increased risk for the neurodegenerative processes? You know that the risk for Alzheimer's disease increases exponentially with aging, and this red line kind of shows what that is. If you do have an increased vulnerability, will the line look more like the blue line? This is what we do a lot of work understanding. So let me tell you just a little bit more about the underlying brain vulnerability that's happening with Martin, likely based on published reports. I've talked a lot about inflammation. The next slide goes right to the meat of the matter. On the right, on the next slide, you can see staining for CD68, the brown staining, and you can see somebody living with HIV compared to somebody who is a normal, healthy HIV negative control. And it should be pretty clear to see the brown staining much more in the left image than on the right. This is somebody who died with HIV and was receiving antiretroviral therapy. A small study that was done out of Edinburgh with about 10 patients. So it was showing that there's CD68 staining. This is a microglia in somebody who died on antiretroviral therapy. The more interesting study is the one to the left that was more recent. And what these group out of London did is they took very healthy HIV positive people without cognitive impairment on therapy with high CD4 cell count functioning normally in everyday life. They did PET scans on about 10 of them compared to controls, and they looked at the degree to which there'd be TPSO binding. This is a binder for microglia, and what they found that is indeed the group of people living with HIV had higher TPSO levels as a group. They went on to look at these people that performed normal on cognitive tests, and what they found is that the higher the TPSO binding, the worse they did on executive functioning tests. So there was an inverse correlation, even though it was normal performance. Within that normal performance, there was an inverse correlation between TPSO binding, thought to be a marker of microglial activation, and performance on executive functioning tests. This is the background of cognitive reserve I'm talking about. People living with a chronic fluctuating encephalopathy that can be measured in these types of studies. If you go to the next slide, this is a paper that I published out of the Women's Interagency HIV study in 2017, looking at CD14 and CD163. These are both markers that are on monocytes, and when they become activated, they cleave off and become soluble products that you can measure in plasma. What we found here is that the higher the level in virally suppressed women in the US, the worse they did on all these cognitive measures. So you can measure in blood these monocyte-related markers and find a correlation to cognitive performance in people that are on therapy and suppressed. So I think there's a substantial amount of evidence that this is what's going on. If you go to the next slide, Martin was probably in this study, which showed that we have worse DTI in people living with HIV. So this is measuring the integrity of the white matter tracts. And we find that in people living with HIV, they have more impairment in white matter tracts, and that impairment is even worse in people that are ApoE4 positive living with HIV. Camelia, I think I've got my slides mixed up. If you could slide ahead 2 slides for me. It's what I want to talk about next is this paper we published last year showing that the integrity of the white matter tracts the poor integrity was inversely correlated to higher levels of inflammation in plasma. So we measured inflammation in plasma. We found that the higher the amount of inflammation, the worse the integrity of your white matter tracts was by DTI. So we were able to correlate structurally in the brain what we're measuring in the plasma, demonstrating inflammation. We took a step further and looked at the DTI signal and found that it correlated with executive functioning. So in this paper that was published in AIDS last year, we found that you can correlate blood inflammation to poor integrity of DTI, which then correlates to poor function on executive functioning tests. These are suppressed individuals that have been on therapy for a very long time, are doing reasonably well in community. They're functioning reasonably well, but they have some cognitive symptoms and inefficiency that made them come and join our study. If you now go back 1 slide, Camelia, This is just a couple demonstrations of the white matter lesions we sometimes see in about a third of people living with HIV. We can see a pattern that looks like cerebrovascular disease in the upper slides, but we can also see in quite a few people this pattern of more discrete lesions on the bottom. And the burden of that white matter lesion seems to correlate as well to executive performance. So not only do we have an HIV-related challenge for people living with HIV, but there's also a higher rate of cerebrovascular disease as measured by white matter lesions. This is very consistent with an autopsy study that was published around 2010, showing that 50% of people who died with HIV had moderate to severe atherosclerosis in the brains. In fact, atherosclerosis is the leading pathology seen in people who die of HIV today. We don't see the encephalitis that we used to see in people that are treated. What we see as a leading pathology is higher level of cerebrovascular disease. And sorry to have you skip around, but now if you go ahead to, this is the last study that I wanted to show. This is also work that we did at a UCSF, where we looked at people who were living with HIV and were suppressed and followed by us for at least 3 years. And we know that they were virally suppressed the entire time. We compared this to a group of healthy people that Joel Kramer was kind enough to share with us from the Hillbloom cohort. These are very healthy people. So we're comparing HIV and all the comorbidities that maybe exist in HIV to people who are healthy in the Hillbloom cohort, who are largely excluded if they have substantial comorbidities. I say that in that way because we do see accelerated atrophy across the brain, but whether we can completely attribute it to HIV is harder to say, because not only are the differences HIV, but they're not demographically matched, because the Hillbloom cohort looks at very healthy individuals. We just finished an analysis that's being submitted for publication showing that this atrophy is not only due to cerebrovascular disease. So when you look at cerebrovascular disease, you could expect scarring and maybe some atrophy that would correlate with that cerebrovascular disease. We've now looked specifically to see if that explains the amount of accelerated atrophy, and it does not. In fact, Joel may not know this yet, I don't think he's seen the paper, but we see this, that people with cerebrovascular disease, whether they're HIV positive or HIV negative, there is a correlation to atrophy rate, but the effect sizes do not differ between the HIV positive and the HIV negative. So we're seeing that correlation, which is not surprising, but it's enough to explain this accelerated atrophy that we're seeing in people living with HIV. And again, I point this out only because of the brain reserve phenomenon. The next slide, if you're really interested in the topic, you can look at this paper, or we'll share the slides and you can look at this slide. It's a compendium that Benedetta Milanini, a PhD neuropsychologist in my group, pulled together for a review article, just asking how will we be able to differentiate HIV-related impairment from Alzheimer's disease? Can we use cognitive patterns? Can we use a motor exam? Can we look at behavioral factors? Can we use imaging, DTI, MRI? Can we use histopathology? Looking at CSF, for example, can we use ApoE4 and other genetic factors? And it kind of summarizes what's known in the literature around what could be used and could not be used. And the challenge is that really there's a lot of potential overlap, and there's a potential for people living with an HIV-related impairment to look like an Alzheimer's-related impairment. The one finding that seems to be emerging is that CSF may be helpful. When it's normal, it's helpful. When it's abnormal and consistent with Alzheimer's disease, it seems to be helpful. But about a third of people in my clinical experience will have an alteration of either amyloid or tau, and so it's not helpful. And the reports will come back as equivocal. But increasingly, I think that may be a useful tool. If you look at the next slide, this is a work that Benedetta Milanini, Dr. Milanini did as well. And she looked at all the neuropsych testing and tried to model the differentiation. She found that there was an 86% accuracy, predictive accuracy, looking at neuropsych testing. So this is work that we're going to continue to do to see if we can identify more clearly how we can provide guidance to clinicians. So let's bring this back to Martin. Next slide. What do you want to tell Martin? What should I tell Martin? What's the likelihood that Martin, at 72 years of age, with a first-degree relative, having Alzheimer's disease and having confrontational naming abnormalities on neuropsychological testing, including some problems with animal naming. What's the likelihood that he has Alzheimer's disease? How can I tell the difference? I've told you imaging doesn't really help. I've told you lumbar puncture might help. Well, when I saw Martin, the next slide, he was lucky enough to enroll in a study run by one of my colleagues, Gil Rabinovich, and we were able to get an amyloid PET image, and his amyloid PET was negative. So we were able to exclude Alzheimer's disease, and essentially because of the presentation, neurodegenerative diseases, and we felt that the etiology was HIV. I immediately asked him if we could do a lumbar puncture just to make sure that the virus is suppressed. It's a very rare phenomenon called CNS escape. And he said, no way, I'm not getting an LP. I just wanted to know if I had Alzheimer's disease, and he disappeared. He came back into our studies several years later, and he did undergo the LP, and he was suppressed in CSF. But it's a very interesting story to say, you know, this person was more worried about having Alzheimer's disease. And once I was able to reassure him that at that time, it didn't appear he has Alzheimer's disease, it was a hugely satisfying piece of information for him. I tell you that because when I present this type of work to neurologists who take care of HIV, they say, well, follow them for 3 years. And if it gets worse, you'll know it's Alzheimer's disease because HIV isn't going to move along like that. What an incredibly unsatisfying answer if you're a patient. And, you know, do you really want to wait 3 years to know what your diagnosis was? So, and you could see that in the way this individual, you know, responded to me. So let's go and kind of close this up, these two things. What are the common themes here from PSAC and from Martin? First of all, despite optimal therapies, sometimes in ways that exceeds what can be done in clinical care, such as our work that we do out of Bangkok, Thailand, brain vulnerability appears to be a common theme, at least for some individuals living with HIV. So this vulnerability, perhaps in a third to half of people, worries me as they age and for good, healthy brain health as someone ages. To me, the underlying mechanisms appear to be linked to activation of the inflammatory pathways, particularly those related to monocytes, possibly because of reservoirs that exist around the body. You may have heard in my talk that we can often measure plasma markers of inflammation to have it correlate to CNS findings. That suggests to me that the etiology for the inflammation doesn't necessarily have to be in the brain for it to have an impact on the brain. It could be from reservoirs that are in lymph nodes or other places, you know, in the body that are leading to this level of inflammation. If you go to the next slide. Although not a leading cause of dementia because HIV doesn't tend to cause a progressive cognitive impairment, and I say that in a very careful way because it does in some cases, and I've personally seen cases where people progress to dementia and die, even though I've done everything I know under the sun to try to treat it, but this is rare. So even though it's an impairment, it's a leading cause of impairment around the world because of the sheer magnitude of people living with HIV around the world. It's the leading cause of cognitive impairment in people under the age of 60. And as HIV-infected patients age, there's a real question about vulnerability. I have only one more slide because I wanted to end on something a little bit positive. Many of you have seen this paper from Jill Livingston and others that was published in The Lancet about brain health and protecting the brain. I think this applies in spades to people living with HIV. We really need to treat these potentially reversible contributions to brain health, including aggressive look at cerebrovascular disease, lifestyles, active lifestyles, cognitive stimulation. I think this is where I lean in with the patients that I see living with HIV. We need to treat the disease. People need to be on effective therapy for HIV. I have not, at least in my setting, and I don't think this is necessarily true around the world, I have not seen an individual where the infectious disease doctors are unable to suppress virus and plasma. We have a large compendium of medications now available. This is not true in many places around the world, so I give that caveat. Some places do not have easy access to integrase inhibitors or to some of the safer protease inhibitors. But we need to do everything we can to get people on effective therapies and suppress the plasma viral load. For people really interested in the topic, I can go into a little bit around the CSF viral load. I'll just share with you that it's mostly not helpful in terms of understanding in HIV impairment. There are rare cases where the CSF viral load is higher than in plasma that needs to be addressed, but they are rare, and I think it's a little bit beyond the scope of the discussion today, but I'm happy to talk to anyone individually about that. Manage vascular risk factors. Allow patients to understand that cognitive impairment is a rather frequent finding in people living with HIV, and that it's not likely to progress. It'll be an inefficiency. This is, I think, critical because of the stigma attached to this disease that is accentuated when doctors tell patients that the reason for their cognitive impairment is something they did, whether it be, you know, using a recreational drug, blaming it on too much alcohol. These things may be factors that you want to address with individuals, but please take time to explain to patients that we know there's an HIV-related impairment that's due probably to the inflammation, and that could be contributing to their cognitive syndrome, while you at the same time address these other challenges that people are going through. And certainly, let's treat depression and anxiety in these individuals. There's increasing evidence that this is going to be important for them in terms of sustaining viral suppression, staying on therapy, staying engaged in their communities. And with that, I wasn't sure, I didn't realize I had 90 minutes. I hope 60 minutes is enough, Camelia, but that was my quick overview of some of the things I think about in my research environment on a regular basis. And it's still storming here, so I'm still a little bit in the dark, but I don't know what you do at this point, Camelia, whether you open it up to questions or if somebody's following the chat or how that works.
Thank you, Victor. No, that was fabulous and so insightful. And I think we would love to move to a Q&A to just unlock some of this rich content that you shared. I'll pass it over to John to facilitate the discussion.
Yeah, and so at this point, open for questions. So feel free to enter questions in the chat box, or also I think unmuting yourself and asking a question directly would be fine. Is that right, Camelia?
That's right. Yeah, feel free to unmute yourself. And actually, let's just pause and give Victor a round of applause briefly, please. Thank you. Either with your emoticons or with your hands. Thank you very much.
Well,
and on the road, no less.
No, it's really fun to share some of the work that I do in the other side of my brain that I think people in GBHI don't get to see some of the research that we're doing. So I'm delighted with the opportunity. Thank you.
Wonderful. And there's a lot of shout outs in the chat to you as well. Thanking you.
Maybe to get us started off, as people think about the questions they want to ask. First of all, Victor, this was fascinating. Thank you so much for this very interesting talk. And I hadn't really thought about a number of these issues. I wonder, one of the points you mentioned, you remind us of, is that there's a disproportionate impact of HIV in under-resourced parts of the world. And there's been a huge global efforts to mobilize resources for the more acute stage. But now as we see this as a lifelong disease and it's leading to also comorbidity with cognitive decline, what are your thoughts on how well prepared are the health systems to deal with the disease as it shifts towards this presentation? And are there things that providers or health systems could do in order to deal with this new phase of the disease?
You know, John, that's a very insightful question, and I'll flip it on you a little bit. In many places around the world, HIV is so much more prevalent and frequent and done very well in an organized way than care of things like diabetes. In fact, Diane Havler has an entire project that she's got funded to leverage the infrastructure of HIV to provide care for people with other chronic diseases. And in my own personal experience, talking to people as I travel around Uganda, Kenya, and places, you certainly see that if an individual is living with HIV, they're getting care on a regular basis, which bleeds over into the care of their diabetes, their care of hypertension. Many clinics were not allowed to treat those diseases. They were supposed to refer them out to other doctors. But as we began to see this transition, many clinics are now beefing up to be able to do that. And in fact, there's almost a negative effect for individuals living with these chronic diseases who don't have HIV and don't have ready access to all of this. The fact that you have to be seen by a clinician to get your antiretrovirals on a regular basis means that you're accessing care for these other treatments. So being able to provide the infrastructure is really more moving towards allowing care for those other things. And I think, as has happened in the US, empowering infectious disease doctors to provide primary care. Many infectious disease doctors in the US are primary care physicians. And they take care of everything. I mean, the challenges are I mean, I take my hat off to these individuals who provide not only outstanding HIV care, but outstanding care from all the aspects. So I think there is a little bit of a transition thinking about the chronic diseases, but the infrastructure is stronger in many places around the world than it is even for individuals who don't have HIV. So there are lessons to be learned. The infrastructure and the partnership, I think, for how HIV is rolled out could be a very good model for public health delivery in many places around the world. So it's a very insightful question with not a straightforward answer because of these things that are happening, these factors that influence the process.
It's really encouraging to hear, and hopefully we will be able to learn and implement some of best practices that are applied elsewhere to some of our own health systems. And I'm seeing some questions starting to come in. One from Brian Lawler: is there any evidence that antiviral therapy in people with HIV could actually decrease the risk of AD, of Alzheimer's?
There's that's a nice question, because there is a paper that was published in the last year arguing just that fact, that the argument was that since we haven't seen many publications of Alzheimer's disease in people living with HIV, and there are so many people living with HIV, that the frequency is likely lower. And these individuals found they postulated that the antiretroviral medications may help influence the Alzheimer's risk. Personally, I think there aren't data on which you can really inform this effectively. Certainly, the hypothesis of inflammation around Alzheimer's disease comes up with frequency, and having access to antiretrovirals might, that's why I don't want to completely exclude that possibility. What I see in clinical practice, however, is that individuals have a vulnerability often of either, the images that I see, I could share with the team. It's sometimes profound atrophy, sometimes profound white matter changes. This, I think, is going to be much more influential in terms of their risk than taking an antiretroviral. But I don't have data for it, and I'm not very optimistic that to have a positive influence on the risk for Alzheimer's disease, but I don't have good data to tell.
And then there's a question from Primrose, and actually, Primrose, I wonder if you're still on, if you might want to share some of the comments that you offered in the chat, and also ask your question to Victor.
Hello, yes, I'm still here. Thank you for the very insightful talk. I had a question regarding the high prevalence of neurocognitive impairment in sub-Saharan Africa, like you said, and that it affects, the day-to-day activities of these people. So I was wondering if you have any thoughts of interventions that could be done for these people.
Yeah, thank you for the question, Primrose, and I hope that you'll continue to work on some of the HIV work you've done over the past decade. You're in really kind of a pivotal situation where you can have an influence on brain health in your community, and the work that you've done and the work that you can continue to do. There are no adjuvants. These people often want to know, can you take pills to kind of treat that? There are no adjuvants that work. So certainly getting people on antiretroviral therapy, getting them on a therapy that they can tolerate well is important. some of the antiretrovirals do have cognitive side effects. So the classic example here is, using efavirenz in somebody who has depression, probably not a good idea, could make the depression worse. But we also see that people can get a lot of headaches with AZT. And so trying to get a therapy that works really well and getting them suppressed on it. Identifying that there is a cognitive impairment and not blaming the patient or what they're doing, but empowering them. And because this is an inefficiency, it's quite amenable, I think, to compensatory measures. So, for example, using reminders on a phone, using lists to go shopping. It also may be amenable to doing one thing at a time instead of 2 or 3 things. Just trying to sequentially work rather than doing things all at once. Staying socially engaged. I've even asked patients whether they're comfortable telling their friends that they have a cognitive syndrome so that they'll slow down the talk or repeat things in discussion so they can remain socially engaged. The stigma often is a challenge in that component. Not only many of my patients have overcome the stigma of HIV because they've been living with the disease for so long, but now there's the added stigma of having a cognitive disorder. But those are the types of things that I talk to my patients about in how they may try to address this. And certainly treating, depression, anxiety, in many places I work in the world, gender-based violence and PTSD, trying to address those things that can really augment an underlying HIV impairment to make it worse functionally than if they weren't treated. So having a very close eye to those things and trying to get them treated. Thank you for the question.
Thank you.
And we have another question, a couple questions actually from Boone Lee. Boone, would you like to pose your questions to Victor?
Oh yeah, sure. Thank you so much for the very insightful talk. So I was actually a bit wondering, so if we think that, HIV-related cognitive impairment is mainly driven by inflammation, and since, AIDS is, if not well controlled, it's an immunocompromising disease. So like, does AIDS individual with a low CD4 cell count, would they have a lower rate for cognitive impairment? And if not, then what is their pathophysiology that led to any cognitive deficits? And I guess, and also to follow on the previous question, how do we differentiate HIV-related cognitive impairment versus heart-related cognitive impairment clinically?
Yeah, thank you, Boonli, for the questions. Not surprisingly, difficult questions. The first question I think I understood is, is there a higher risk or a lower risk having a lower CD4 cell count? Remember, the CD4 cell count is only one very specific measure of inflammation. It doesn't necessarily correlate to monocyte activation. High or low cell-based immunology doesn't necessarily correlate to whether your CRP is going to be elevated in your plasma. So the CD4 cell count is just one of a kind of a ubiquitous, gamish, challenging, network of immunologic inflammatory components that your body goes through. So I wouldn't expect the one component being lower necessarily correlating at all to any kind of protective component, particularly the CD4 cell count. And certainly as people have lower CD4 cell count, they begin to get a higher risk for opportunistic infections to the brain. So we certainly don't want to allow that to happen. The lower your CD4 cell count has been in the past, the lowest we call the nadir. The lower that is, the more likely you are to have a cognitive syndrome. That may represent past old injury and how severe your disease was. So that may answer that piece at least in part. And I would say the last thing is I have a handful of people who, despite being on therapy, don't have a very high rise in their CD4 cell count, including people who are still around 150 and 200. And I don't particularly consider that to be a protective or damaging in terms of their risk for cognitive impairment. So the question, can I just do a check to make sure people can hear me? Can you hear me? I hear some funny noises. I think it's just people on the call.
We can hear you. It's going a little in and out, but we can hear you right now, Victor.
Okay.
Yeah, keep going.
Okay. Oh, I know what the noise is. It's my speaker. I have to take my headset off. There, I think it's my earbuds that were making the funny noise. Can you hear me now, Camelia?
Yeah, yes, we can hear you now. That's good.
Yeah, my ears are going dead on me. All the batteries are dying in this rig. Your second question, Boonlead, was how do you differentiate an HIV-related impairment from a antiretroviral drug-related impairment? And I'm not sure you can. There was a nice study done back in about a decade ago. We thought that because the antiretrovirals were damaging mostly to the heart, that we should have people go on and off them from time to time. So you get the CD4 cell count up, you take them off antiretrovirals, you let them live without being on. We call those drug holidays. And then when their CD4 cell count dropped, we put them back on so that they would never be at risk for opportunistic infections, but they would have some kind of a holiday from the toxic effects of antiretrovirals. Somebody did a piggyback study on that, looking at cognition during those times. And in fact, people improved cognitively when they came off the antiretrovirals. So it was pretty good evidence that, in fact, the antiretrovirals are contributing to a cognitive impairment. I think that leads some people to say, well, that's all it is. You know, it's not a real cognitive impairment. To them, I would say, look at the inflammation, you know, the inflammatory correlates that I have. So from a mechanistic standpoint, I think we have the answer that they both contribute. The contributions, the relative contributions, I don't know how to begin to answer that. And differentiating the two, I don't know if I could easily answer that. I tend to ignore the antiretroviral contributions because I can't do anything about it, and acknowledge that they may be contributing, but in all the people that I see, I don't ever blame it entirely on antiretrovirals. I discuss to them that it could be contributing, but then we put it to the side and say, there's nothing I can say more about that. You have to be on, don't stop them. Recently, I saw an individual who took antiretrovirals 3 out of 7 days of the week, and he told me that he was always suppressed. And I asked him, well, when did you go get your blood test done? On day 1, day 2, day 3 of when you're on antiretrovirals? And he kind of joked with me that it didn't matter, but it does matter. I think that, you know, what I told him is you're living with a cognitive syndrome. I'm worried that you're not getting adequately treated. Take it every day of the week. We did treat him every day of the week, and his balance problems entirely went away. So I was able to see that maybe he wasn't getting adequately treated, although he still has a cognitive syndrome. I won't be able to differentiate whether that's due to antiretrovirals or not. You can switch the antiretrovirals, but I wouldn't do that. These are very complex regimens. ID doctors know which ones are best, not only for the brain, but for the liver, the heart, the kidney, all the organs that can be affected by these drugs. So I let the ID doctors lead that, and I don't tend to play with that unless, as I said, somebody with substantial depression I happen to see still on efavirenz, which probably shouldn't be done if there are options these days. Thank you for the question.
Michael, you said something toward the end of your talk about CSF. I thought what you said is that CSF viral load is not as good an indicator as blood viral load, or maybe I missed that.
Yeah, Michael, for you, I mean, and the people that you see, if you see people with HIV, and I think for the neurologist, this is a very important topic, and I'll just spend a few minutes talking about it. If you're looking at run-of-the-mill cognitive impairment and people coming into the clinic, particularly the ones that I see that have been living with cognitive impairment for many years, and they want to know what it is, the CSF viral load is not very helpful. It'll be suppressed, and if it's suppressed in plasma, it'll be suppressed the vast majority of time in the CSF. So using it diagnostically to say, oh, this is an HIV-related impairment versus not an HIV-related impairment, it's not useful in that capacity. But when you and I see people that are, you know, a little bit more subacute particularly, and sometimes even more chronic, I worry about this very rare phenomenon called CNS escape. The virus in the CSF is elevated even though it's suppressed in plasma. And in these cases, they do need to have their antiretrovirals changed, and they do get better. But it's very rare. And it's something that you and I need to be very keen on. I end up doing more lumbar punctures than I want. Some of our trainees at UCSF have identified cases of CNS escape. We've corrected this CSF virus and they didn't get better. So there's this asymptomatic CNS escape. But certainly if you're seeing patients in the hospital, you're doing an LP on somebody with an acute mental status change, the CSF viral load is exceedingly important to measure in those circumstances. But as a general rule, in people living with cognitive impairment over the long run, not so much. And I can share some of those papers with you if it's helpful, but I think you probably are aware of those data already, Michael. But this is an unusual phenomenon of CNS escape that I think neurologists, particularly those working in hospitals, need to be aware of and think carefully about. But for the vast majority of cognitive impairment that we see in the community, this would be a rare phenomenon.
Thanks.
Other questions, audience?
And I just wanted to give a quick shout out to some of our senior fellows who are joining. We have folks still with us from Botswana, Mexico, Spain, Peru, France, Egypt. So welcome to you all, and thank you for sharing your positive comments in the chat. Victor, I actually have one question, which is, what future areas of research do you see? Just areas that need additional exploration?
Yeah, thank you for that question. We're putting in a number of grants this fall, so I hope I have a good finger on the pulse of what the questions are that need to be answered. One for me is really this whole idea about how do we get the 90-90-90 achieved? So what are the behavioral strategies? How do we really take identify people with cognitive impairment, with depression, with head injuries, the people that are at highest risk for bad outcomes in 3 or 4 years? How do we identify them in a massive way? So we intend to do some, we intend to actually leverage TabCat in a grant and also the brain health assessment to try to get a sense across Africa in our AFRICOS study. Who are the individuals with depression? Who are the individuals with these risk factors? Can we identify it in a 15-minute or 20-minute tablet-based assessment? And then if we can, the next step would be, what approaches can we take to really address this? And there's some great data coming out from Susan Meffert, who's a UCSF grad, talking about group-based therapy, group-based treatments, so getting people in groups that they can get support groups, not using medicines, particularly for depression, that, comparing group-based therapy to Prozac, you find that the group-based therapies are probably better. So that's, I think, really the behavioral approach is to optimizing therapy and getting people on therapy. I think that from a neurologic standpoint, we really have to think about these behaviors. We have to be the leaders in these areas of identifying and treating behavioral factors that are predictors of bad outcome, whether it be not getting tested, not knowing your status, not being on therapy, not being adherent to therapy. I think this is a big area that I hope to do a little bit of work in and I think is important. And then the other piece that I think is important, we can study the mechanisms of brain injury quite a bit. So you can look at the inflammation piece. I think this is still important work. There are people like Adi Nath at the NIH who are very worried about viral particles like TAT. They're probably still a component. So there are some mechanistic angles that you can take to maybe try to treat that cognitive impairment with some form of adjuvant. I think that's an area that still has some work. And then I can't leave this call without saying that this whole idea of diagnostics for people who are 70, 80 years of age is a real challenge. We have no idea if the virus will cause a higher rate, an accelerated risk, accelerated course. I identified Alzheimer's disease in a 79-year-old who died 4 years later from very mild Alzheimer's to dying. That's a very rapid course for that individual who had autopsy-proven Alzheimer's disease. We don't know the answers to this, and it'll probably take large studies to understand the risk for neurodegenerative syndrome. If you ask people, particularly in the United States, what they think is the most important thing, this is right at the top of their list is, am I at a higher risk for Alzheimer's disease, doc? Am I at a higher risk?
Thanks so much. There's some more shout outs too in the chat from Jenny Zitzer. Thanks, Victor. This is great.
Victor, can you tell us about your Airstream trip, where you are, what you're doing, what you've learned in your travels?
My midlife crisis, Michael.
Whatever.
Yeah, you can follow me on Instagram at Victor's 2020 Adventure. I'm learning a lot about who I am. I'm learning about being off the grid. I'm learning about leadership. I'm learning about the U.S. I'm meeting people from around the world who are joining around campfires, telling me what's their challenge, that they're going through. And then I'm reading great books. If you haven't, by audiobook, if you haven't listened to Maya Angelou read I Know Why the Cage Birds Sing, you haven't lived. Her sing-songy nature at approaching reading that book is phenomenal. I've read a lot about Lincoln, and I've been thinking a lot about the Black Lives Matter, and I've been trying to teach myself a lot about the history of that in the U.S., so reading a lot of Lincoln. And then, big shout out, if you haven't done it yet, George the Poet. George the Poet. Read his podcast, George the Poet.
Huh? Phenomenal podcasts about race and society, and it's from the UK, and big shout out for George the Poet. Yeah, so I'm sure that's where are you now and where's next?
I'm in Minnesota. I'm heading up to Michigan. I'll be in Michigan for about a week. Then down to Pennsylvania. I want to see the Amish country, and then up to New York, and then I'm going to hang out with my family in Vermont and work from Vermont for a month. Yeah.
Well, if you're near Madison, Wisconsin, I don't know if you're going by there, but you have to see Taliesin and House on the Rock.
Okay, I'm not heading to Madison.
You're not going to be near there.
John, we probably should get back to the reality of this, and maybe just do a close. I could chat with Michael for a long time, but
I think so. I think this has been terrific, Victor, and thanks so much. And it sounds like this U.S. tour might be building towards Valcor 2024, so I'll have to keep an eye out for that one. Camelia, any finishing, closing house cleaning items?
Sure. So I've just shared a feedback survey in the chat. We'd love to hear all of your feedback. We'll share a recording afterwards and a PDF of the slides with Victor's permission. And just a huge thanks to Victor, to you, John, to Winnie, and Kira and Kaylee, who've been working on this program with me. So thank you, everyone. Just a brief round of applause. Victor, thanks for joining on the road. That's fabulous, and the connection lasted the whole time. So wonderful.
Yeah, precarious. I'll share my thanks to Camelia for your leadership on this, and John and Riley. I think the global teleneurology program is just super. It's a leader in the space, and it's so much needed, and it's such a perfect partnership for GBHI, and with Camelia's leadership and others on our staff. Thank you so much for doing this. I'm delighted to have been asked to share some of my research.
You're very welcome. And we'll all keep an eye out for those suggestions on books and podcasts. And we have some shout outs in the chat about that too. Have safe travels. And John, I'll just pass it back to you for the final.
I think that's it. Thanks so much to everyone. This was a terrific program, Victor. Really appreciate it. And the elements you overcame in order to make it happen. And thanks all for the great discussion. So be well, everyone.
Bye. Thank you.
Bye, everybody. Thanks very much.